Hi everyone, my name is András Nikovic and welcome to this lecture on how to assess LV global systolic function. So we're going to go through the objective measures, how to do them, and then we'll start putting it together and we'll try to show you how to do that good visual estimation. So once you've watched this lecture, you can watch the next one, which is gonna be more on loops and how to develop your skills on that visual estimation. So these are just a few measures that we can do, all sorts of difficult, complex measurements, fancy things that you can do with the echo. However, I'll be focusing more on the visual estimation and that thing called eyeballing the left ventricle. However, I found that in many people's minds, somehow there's a disconnect between that visual estimation and the other objective measures. So even in some lectures that I watched about LV function, first they start with those complex, difficult measurements and they go on and on and on. And then after that, they say that, okay, so let's just forget about all that, but there's that visual estimation and that's your skill that you have to develop. And then they don't say how to develop that skill. So that's why I thought it was important to go through those objective measures first in a simple way. And then after that, I'll give you a bit of a framework on how to develop those visual estimation skills. So these are for your reference. So these are the measures that we can do for an LV global systolic assessment. So you can make these quantitative, meaning that you try to assign a number to that LV systolic function, like an EF of 45% and so on. The other way to do it, and we do this in ICU a lot, is the qualitative assessment, where you don't really care about those specific numbers. However, you want to know whether the LV function is normal, is it hyperdynamic, or if it's abnormal, is it only mildly, moderately, or severely reduced systolic function. So this would be more important in our ICU setting. We do this all the time. We often don't use numbers and just say that the LV function is moderately reduced by visual estimation. So that brings us into that conundrum of quantitative versus qualitative measures. What to do? Do we need to learn all these quantitative ones? And the answer is probably yes, we need to know how to do them. But along the way, as you develop your skills in echo, you start with learning a few easy enough to do quantitative measures. And then you apply these in a sort of a semi-quantitative fashion to form a qualitative idea about the LV function. So I put some examples there. So for example, you can measure out very, very carefully and very accurately an LVEF of 32%. You can do the same with not measuring it out, but just doing your visual estimation. You're estimating it at 35%. Or you can just look at that LV in many different angles, and then you say that the LV function is mildly, moderately, severely reduced. The quantitative measures always remain the gold standard. This is what they use in cardiology. They assign numbers to this LV global systolic function, and it's very, very important. However, in the ICU, often it's quite impractical to expect us to spend a lot of time on detailed calculations, do those thorough measurements, aim for those perfect images. So we can't always do that, mostly due to our patient cohort and difficulties in acquiring those images. So that's why we revert to this rapid visual assessment. And this is a very important part of our ICU or any critical care environment, ED, ICU, or a med call environment for medical people. So that's an important thing to do. However, we do use these quantitative assessments and we extrapolate these into an efficient qualitative visual assessment. And this is what we're going to be covering today. So the basis is always the same. So we still have to aim for the best quality images and under those circumstances where you are. So if it is a difficult ICU patient that you cannot move on various organ support, lots of machines in the bedside, you can't really you won't be able to do perfect images. You just do as much as you can. You still aim for the best you can do. You still do as many views as possible. You still try to estimate these measurements. So I'll give you just a very, very quick example. So that really just takes about a minute to do. You take one quick personal long axis view. You have a quick look at that EPSS. I will explain all of these later on. You will have a quick look at the fractional shortening, and then you take an apical 4-chamber, you quickly estimate that EF, and you quickly have a look at that MAPC. You put it all together, you spend roughly about 60 seconds on this patient. You already have a pretty good idea on how that LV is functioning, and notwithstanding, you already had a look at all the other parts of the heart. Why is this patient shocked? You excluded pericardial effusion and other things, but today we're only focusing on that quick LV assessment. So really, you only need about a minute to very quickly, very rudimentary assessment, but it doesn't require too much time. As I said, good quantitative skills will have to be developed though, and anyone who was an echo fellow or who's a bit more involved in teaching or self-education, you know that it's not an easy thing to do. You have to do a lot of studies, and some people say, and some papers say, that up to about, let's say, 150, sometimes they even say 250, or up to 500 cases you have to do, scanning and reporting those yourself to develop good skills. You still have to pay attention to detail, the best quality images, and repeat. So keep scanning, and that will lead to your proficiency, and you will become a pro, and you will become better and better. So first of all, I will use the 2015 ASE guidelines. So this is the American Society of Echo. Australia is very much using these American recommendations. There are European recommendations as well as British recommendations, and these are slightly different for some reason. Some of the measurements are a bit out of whack, and they couldn't really agree on a uniform approach worldwide. But nevertheless, I'll be covering the ASE guidelines, and these are the American guidelines. This is what we use in Australia as well. These are the things that they stipulating in that ASE guideline for a global LV assessment. And out of these, I will be mostly covering these red ones, and the others will be covered in other talks. So for example, the segments and segmental assessment will be covered in a full talk later on. LV mass I'm not going to be covering at all, so that's something for cardiology, not for ICU. Let's start with those linear measurements. So that's the basic thing that we start out with for every single patient that we do the echo on. You take your Prestonol long axis image and then you stop it and end diastole. You try to find a good image which is your largest cavity, observing the mitral valve leaflets. You drop a line along the mitral valve leaflet tips and you're trying to be perpendicular to the long axis of your left ventricle. And then you do your measurements. You can do 2D image, like on this image here, or you can do this with M mode as well, but that's not recommended by the ASE guidelines, because you can fall off the right angle and the right axis very easily. So what does it look like in real life? You get a parasternal long axis image as you see here. You pause it, you scroll back and forwards, and you observe the mitral valve leaflet, and you select one frame immediately prior to that mitral valve coaptation. So practically you're aiming for the largest LV cavity on that image. Easiest and best to use the mitral valve for timing. However, if that's not feasible, you can't see it very well, or the image quality is not very great, you can use the ECG. However, there is always a bit of a delay, or always a bit of a discrepancy between electrical and mechanical events. So see that little red dot on the ECG there? Usually they say that you pick the frame on the Q wave on ECG, which is end diastole. However, see how that red dot is quite far from that Q wave actually. So there might be a bit of a discrepancy between mechanical and electrical events, and that's just normal. So once you identify the right frame, you try to identify that long axis of the left ventricle, like so, and then you're keeping yourself 90 degrees onto that long axis, and then you drop your caliper lines onto that LV cavity. You will start by checking out or measuring the interventricular septum, so making sure that you're not including too much of that tricuspid valve apparatus and chordae tendineae, so it's only the myocardium. So that's your septum thickness. And then for the LV cavity, from the posterior surface of the septum all the way to the leading edge of the posterior wall, and then from there you do your posterior wall thickness. And then the machine will save these numbers for you. On the M mode, again, this is not recommended by ASC, but can be done, and I still use M mode quite often. It's still a useful modality. The advantage is it's reproducible, you have a high temporal resolution, however, often off axis, and that's why they don't recommend it. So you can imagine that this M mode cursor, so sometimes it just doesn't align well with your LV cavity. It's just not 90 degrees or perpendicular to that LV cavity, but can be done, certainly can be done. You select the LV cavity on that M mode image, and then you find the thickest or widest portion of it, and that's going to be your end diastole. And this one-dimensional measurement can be used as a surrogate or as a number that you plug in into certain equations. So you're sort of checking out the one-dimensional assessment of that prolate ellipsoid, and then they use that to calculate a volume of this. So see how there's a lot of assumptions used in it, and it's probably not very accurate in many cases, especially if there's regional differences in LV function. However, and I mentioned this already here, in clinical practice, in real world, a good majority of patients, like up to 75% of patients, you can use this on as an approximation of a global LV function. There'll be a bit more on this later on. There's your EF, ejection fraction, very important, very useful. Everyone is probably on the same page about this. People understand it. Or different specialties, cardiology, respiratory medicine, ICU, ED, medicine. So we all want to know the ejection fraction of that left ventricle. It's always reported in the echo reports. Everyone goes for that one first because that's a number they can relate to. And it is a very important measure. It is super important, especially in the cardiology world, where very, very important decisions are based on this ejection fraction. For example, when to operate on a valve replacement, or when to change management of a heart failure patient, or when to implant a cardioverter defibrillator or resynchronization therapy. So very, very important. In brackets, I have to mention it right now that in the ICU world, though, less so. EF on its own can be quite misleading, very often can be misleading in various patient groups. So for example, I just give you one example now, and then there'll be a full lecture on this when we're going to be talking about cardiac output. But let's say there is a patient with HOCM physiology, hypertrophic cardiomyopathy physiology, very small cavity, very thick myocardium. Their EF could be 70%. Looks very hyperdynamic, small cavity. They can be in the ICU under your eyes, shocked, needing considerable support, with an EF of 70%. So was that EF very useful in any way for us? No, not really. So we're more interested in perfusion, whether our organs are perfused or not, and then as a surrogate for that, cardiac output, stroke volume, and all those are important quantitative measures for the ICU. EF, very often not that useful. However, we will cover it, of course, we will cover it, because that's a very important measure of a global LV function. You need volume measurements for it. So you get your diastolic volume, you get your systolic volume, you plug that into this equation, and then you get your EF, ejection fraction, as a percentage. Volumes can be derived either via 2D or 3D methods. And currently 3D is recommended. It's not available everywhere in the cardiology world. It gives you very good numbers. 2D assessments are fine as well. EF is very dependent upon loading, both preload and afterload. So it does not only reflect ventricular contractility, and that's why it can be a bit tricky to make sense of those EF numbers in the ICU setting. So let's start with some volume measurements. If the Simpson's biplane is not available for whatever reason, ASC does recommend the area length method, which is a number 2 option after the Simpson's biplane. So you can use this if you want. I don't tend to use it very often, but it is recommended by ASC as an alternative way of measuring volumes. You see you need 2 measurements. In the apical 4-chamber view, you do an LV cavity length measurement. And in a parasternal short axis view, you do an LV area measurement. And then from that, you plug that into an equation, and that gives you a volume. So you do this twice, at end diastole and at end systole, and then you can calculate your ejection fraction. There's a few caveats. So foreshortening is always a caveat for these measurements, but this one also uses some geometrical assumptions, very limited published data available, yet it is still recommended if the other one is not available, which is this one. So the modified Simpson's biplane, which is your gold standard in assessing ejection fraction in a patient. The measurement is quite finicky, and it requires a lot of experience and a lot of patience as well. So you need very good quality images, meaning that you need to have good endocardial definition, which is not often the case in the ICU. Then, once you have that good endocardial definition, you trace the blood tissue interface in two planes, so that's why it's a biplane method. So you use your apical 4 chamber and your apical 2 chamber images. You identify a large cavity size, which is an end diastolic cavity, and you identify a small cavity size, which is an end systolic cavity. And then you do this twice in apical 4 and apical 2, and it follows that you try to ascertain volumes by measuring 2 dimensions. The machine will divide the length up to 20 little discs in each of these images, and then the machine will calculate the volume of each disc, and then they summate, they put it all together, they add all of that up together, so then you're gonna get that volume calculated for you once you've done these measurements. If the endocardial delineation is not optimal, which again it's very often the case in ICU, you can use contrast, which we call these days ultrasound enhancing agents, and I'll be talking about these again later on in a separate talk. So you can use these. It gives you a much better way to check the cavity size, as you see here, and it is recommended to do in ICU as well if your images are suboptimal. So a few tips and tricks. You need to trace the compacted myocardium. So trabeculations are inside the cavity. Trabeculations are part of the cavity. Once you find the mitral valve, then you close it off with a straight line, and then you drop that cursor, and in the middle there'll be, just at the halfway point, you drop your length line, and then after that your machine will calculate, the 20 little discs up here. When you do this length measurement, so the length itself, as you see here, so when you check the apical 4 and apical 2 chamber length measurements, they have to agree pretty well, so within 10% of each other. So it means that you need to be right on the apex when you do your images from the apical views. So then you're gonna get roughly the same length. Foreshortening is a big issue here, so you need to avoid foreshortening because then volumes will be less. How do you optimize your image for this? So you're not interested in anything else when you're doing this, so you need to fill your sector mostly with that LV in it. So you're not interested in the RV, you're not interested in any other cavity or chamber, you only want to optimize yourself for the LV. You use your harmonics, you use your focal zone correctly, your gain and TGCs and dynamic range, all to provide yourself with the best chances to find that good endocardial definition. You try to avoid foreshortening, of course. If it is foreshorten the image, when it means that your apex is not pointy, but it's very rounded and it's thick and it's contracting and thickening too much, then chances are that you're foreshortened. Then you go lower down on the chest, you drop a rib space, or you go out further, more lateral. You should use the same beat and then use that end diastole and end systole from that same beat. However, that's only for sinus rhythm. If the patient is in an arrhythmia, AF, then you have to do this 5 times and then average it. So you can imagine that you have to do all of these measurements and tracings and selecting the images and measuring 5 times and then averaging it, which is extra labor intensive. So it is very time consuming. So I've never seen anyone doing it actually like that. I mentioned it already. So the apical 4-chamber, apical 2-chamber length should be within 10% of each other. When your LV is partly cut off from that screen, do not extrapolate or guess. And then when your endocardial border is not very nice, then use ultrasound enhancing agents. That was your Simpson's biplane. I'll be talking about this more later on. Another method of measuring volumes according to the ASE document is 3D measurement. So when you have a 3D probe for your ultrasound machine, you can do a 3D measurement which doesn't use any geometrical assumptions. Foreshortening is less of an issue. It gives you a bit of a higher volume than the conventional Simpson's biplane. And these are some normal values that you see here for EF and other things. So see how the normal EF is quoted here as a higher number as what we do for the normal echo measurements. And this is how it looks. It's just magic. It's really awesome. And it gives you just put your probe on. It's a bit bulkier. It's a bit harder to do, like to hold the probe itself. I've seen it a few times done. We don't have a 3D probe in our ICU, but it gives you a volume of diastole and then a volume of end systole. And from that, they're going to give you a stroke volume and they're going to give you an ejection fraction there. And if you know your heart rate, then you can calculate your cardiac output. So that's all very good, but this is not widespread, especially not in the ICU. All right, so everything we talked about so far, LV linear dimensions, LV volumes, and EF by biplane measurement. So these are your normal values. So when do we start to worry? When your LV is more than 58 millimeters in a man or more than 52 millimeters in a woman. And these are your normal values for EF. And I'd like to point your attention that the normal cutoff is not 50%, unfortunately. So for males, the lower end of normal is 52%. And for females, the lower end of normal is 54% for the normal EF. And these are your ranges, the abnormal ranges. So for your reference, so this table is again from the ASE guidelines. That document is freely available on the internet. So if you're more interested in these things, I would certainly recommend you downloading it and read it. So as you see here, normal range lower end is 52%. And then 40 to 50, 30 to 40, less than 30. same for females. And the higher end, so 72%, so I'll stay here for a little while. So that's normal for male, and that's normal for female. So remember these numbers. So this is your normal EF, so for males and for females. Anything more than that is considered hyperdynamic. And then see here, mildly reduced, moderately and severely reduced systolic function. So these are the ones that you need to know. All right. Another way of assessing global LV function is strain, which I'm not gonna talk about at all because I don't know much about it myself, but it is part of the ASC document. And it is used in cardiology labs more and more. They use the speckle tracking method, which is angle independent. So the machine will identify certain speckle signatures in the myocardium, and they're tracking the movement of that. And they assign a number to it. So as you see here, so they look at the relative length change of the myocardium between diastole and systole. So the change itself will be negative. So it means that the value that they give to this strain number it's a negative number. That on its own is a bit of a confusion generating thing. But nevertheless, I don't use it in ICU. I think it's a bit too early. It's a research tool in ICU yet. In the cardiology lab, they use it for certain patient groups, I think, for cardiomyopathies due to chemotherapeutic agents, and for example, amyloidosis, they use it on as well. All right, so that was your ASC guidelines, and that's an important thing to note and to know about these guidelines, because that's what's governing our life in the real world ICU, which is slightly different, but it's all based on these measurements that I have already highlighted for you. I already mentioned briefly that the EF itself is not that important under certain conditions. So I already mentioned one example, which is your severe HOCM physiology. The patient can be shocked, severely shocked, with an EF of 70%. Another good example could be just imagine a severe mitral regurgitation, where your EF, the measured EF or the estimated EF, can be erroneously quite high. So the number itself can be quite high. However, some of that EF is not contributing to your actual cardiac output because it's going backwards into the left atrium. So it's not contributing to oxygen delivery to your tissues. So that's another way of thinking that, EF is important as a concept, but many caveats in the ICU world. And ultimately, we're really only interested in oxygen delivery and organ perfusion. And we're trying to use the echo to look at certain parameters to try to use those measurements as surrogates for cardiac output and add that as a surrogate for the oxygen delivery to tissues. All right. Remember, from the ASC guidelines, I went through how to measure LV cavity and LV wall thickness. So that's an important thing to do in the ICU world as well, because it gives you an idea on chronicity. Is that LV dilated? Has that patient had enough time to dilate their left ventricle? Is that LV hypertrophic? Because then, of course, the pathology has been going on for a while. Is that wall thin? That's the other end. So again, it gives you a bit of an information on whether that's aortic regurgitation. Is it an acute or a chronic thing, or that mitral regurgitation, is it acute or chronic? All right. So we like to break down our ICU measurements into 1, 2 and 3 dimensional measurements. So one dimension is a length. So that's what we already discussed as a cavity measurement. So you're measuring the length or the diameter of that LV cavity. You can use your 2D or you can use the M mode. And again, generally M mode is not recommended, but you can still use it for the fractional shortening. We use the M mode for the MAPC, which is your mitral annular plane systolic excursion. And we use it for EPSS, which is your E-point septal separation assessment. So M mode can be useful in a number of measurements, actually. Let's talk about fractional shortening first. We're trying to estimate the global LV function from a change in ventricular cavity size measured at the base. So this is when we put it into action, what I already discussed with you. So either from a parasternal long axis as a 2D or an M mode image, we do look at it, or later on I'll show you we can do it on a parasternal short axis as well. We do two measurements. We do one internal diameter measurement in diastole and an internal diameter measurement at end systole at the mitral valve leaflet tips. And then we plug it into this equation, and that gives you a fractional shortening. Very prone to errors, so I have to point it out. If there's major regional wall motion abnormalities, like for example that segment that you're actually doing the measurement on, that cannot be a global assessment then. Conduction abnormalities like an abnormal septal motion, chamber enlargement. So it is prone to errors. However, again, I'd like to point it out that it is mentioned in ICU echo textbooks and papers that it's still a useful measure to do, and it's still a useful enough one piece of your puzzle, and I would certainly recommend doing it. This is how you do it. So you take an end diastole, which is on the upper part, and then an end systole. You do the same principles that I already mentioned. You identify the long axis of that left ventricle. You try to maintain 90 degrees onto that long axis. You measure the wall thickness. You measure the cavity internal diameter in end diastole. You do it again in end systole. And then you plug it in, and then the machine will give you a number for fractional shortening, which was given here as 19%. So that's your fractional shortening. I'll point it out here. I'll be talking about it, I think, in the next couple of slides, that they will calculate an EF on these numbers as well. So based on one-dimensional measurement of this LV, they plug it into an equation called the T-Colts equation, and they can come up with an EF based on just these two measurements, internal diameter twice. So again, same caveats, but it's reported on this first screen. So then you can kind of look at it and put it in your patient assessment. That was your 2D image. You can do the same thing in M mode. So you drop your M mode cursor, trying to maintain a 90-degree angle on that LV long axis. You need to be, so just if you critique this image, you need to be a bit closer to the mitral leaflets tips. So then you do two measurements. You identify the large cavity, which is end diastole, and then you identify the small cavity, which is end systole. You plug it in, and then the machine will give you a fractional shortening, which in this case is 33%. That's your parasternal long axis image. You can do this in parasternal short axis. So this is your parasternal short axis. You drop your cursor line into the middle of that left ventricle between the papillary muscles. So try not to catch those pap muscles. And then again, same principles. You identify a large cavity and a small cavity, which is systole and diastole. You plug it in into your machine, and it will give you that fractional shortening of 35%. These are your normal values for fractional shortening. It's a bit of a not very self-explanatory or not intuitive much, but the way I remember it, so the actual number of the fractional shortening is roughly half of the normal values for EF. So if you look here, so the severely reduced fractional shortening is about 15%, which is half of the EF number, which is severely reduced EF is less than 30%. And again, same for all the others. And as you see here, so the normal value, the lower end of normal, 27-25, so that's roughly half of the normal value of the normal EF of 52 to 54%. So one way to remember these numbers is it's roughly the half of the numerical value is roughly half of the EF numerical values of the same category. And then certain equations can use it. I already mentioned one, the T-colds. This is another one, quinons. It uses the same, just a one-dimensional measurement. So you mention one dimension, and then you plug it into an equation. Same for T-colds. You mention one dimension and then plug it in, and then it gives you a volume. Same caveats as for fractional shortening. All right, let's move on to MAPC. MAPC is your mitral annular plane systolic excursion. You probably heard of TAPC, which is the same for the tricuspid valve, and it's a right ventricular systolic function measure. So it's very similar to that, and the actual measurement is, the method is exactly the same as for TAPC. However, in the right ventricle, it's a bit more established because the right ventricle is mostly moving up and down in that longitudinal fashion. The LV is more complex. It does longitudinal, circumferential, and torsion kind of movements, and we only measure one out of these, the longitudinal one. So it's more of a stretch for the global LV function. However, it's been found that it's a good surrogate for a global LV function, so hence we do it. So how do we do it? So you need an apical 4 or an apical 2 chamber image. You drop your M-mode cursor line through the mitral annulus. You can go either lateral or the septal annulus. You do either only the lateral or both and then average them. You start your M mode and then you aim to see the displacement or the movement of that mitral annulus. So it means it's a length, it's a measure of length, how much it's moving, what length it's moving from a trough all the way to a peak. So that's how much it's moving in systole towards the apex. So there's a movement of that LV base towards the apex. And as you see here, these are your normal numbers. So more normal would be 10 millimeters and above, and it's correlating with more than 50% EF. If it's less than 8, then it's probably less than 50% EF. So you can use it as a sort of a rough guide to differentiate between normal and abnormal. It's probably not much better for anything else, but again, it's just one measure. Another measure that you can do and you look at and put it into your big picture and then use it as an assessment for your LV. It's very easy to perform for starters, for novices, so I would certainly recommend trying to practice it when you start learning how to do echoes. It's a bit more forgiving with image quality, so you'll be pleased to see that you don't need perfect images to have a good MAPC. And the caveats, you can imagine that if there's any issues with that mitral annulus, if they had a surgery, a ring, or a mitral valve replacement, or a severe calcification, or for that matter, you might have issues with constrictive pericarditis, like other things like regional wall motion abnormalities. So these are all caveats when this measure cannot be used. All right, let's move on to the next assessment, which is E-point septal separation. I've seen this used more often in the ED world, and a lot of papers come from the ED literature stating the usefulness of this measure. And it's a simple enough measurement, and it's easy to do, and I would recommend using it. So you identify the early diastole, where as a normal phenomenon, the anterior mitral valve leaflet comes very close to the septum, and it can even briefly touch the septum. So that's early diastole, rapid ventricular filling. You can imagine that those mitral valve leaflets, they open, and then as they open, blood filling up the left ventricle, these mitral valve leaflets, they are nearly touching, or the anterior mitral valve leaflet is touching the septum. So you identify that E point, which is the early diastole movement of that mitral leaflet. And then you want to see how close the mitral valve leaflet comes to the septum. So as you see from these two first points, the lower the number, the better the LV function is. So as your LV dilates, as your LV fails and dilates up, then it means that the mitral valve leaflet will be further and further away from that septum when the LV fills during diastole. So it correlates with less and less LV function, worse and worse LV function. So when the EPSS, E-point septal separation, is very low, so less than 7 millimeters, then you get a normal EF. If it's getting higher than that, so the number itself is increasing, then you get into the abnormal EF territories. And if it's more than 18 millimeters, so that's a quite high number for it, then you see that corresponds with an EF of less than 30%. Same caveats as for MAPC, because any sort of mitral valve leaflets, so fixed mitral valve deformities, mitral stenosis, major MR, annular disease, operations on the mitral valves, all these are caveats when you can't use this. What does it look like in real? So see on the left-hand side, you have the parasternal long axis image. The anterior mitral valve leaflet is circled there with red. So see how close it comes to the septum, nearly touching the septum. So even if you don't measure it, even if you don't drop your caliper down, you can kind of say that it's 1 or 2 millimeters away from that septum. So that's certainly a normal number, less than 7 millimeters. You can do this in this 2D image, or you can do it in M mode, where you drop your cursor line through the mitral valve leaflet and you observe the mitral valve movement. So early rapid ventricular filling, that's your E point, and then your diastasis, and then the atrial contraction, which is the atrial kick, and then the mitral valve closes, and then the next diastole comes again. So see, that's your normal mitral valve movement. So this is your E point, this is your A point. And so you identify your E point and you measure how far that E point is from the septum. Simple measurement. All right, so these were your one-dimensional measurements. So let's move on to two-dimensional measurements. Fractional area change, where you trace the endocardium in a short axis image in the mid-papillary plane. And then You do this twice. You need an end diastolic area, you need an end systolic area. You plug it into your equation, and then you get a fractional area change. So you can kind of imagine that in diastole your cavity or the area will be big, and then in systole your cavity will be smaller. So then you calculate the difference between these two areas. Normal range is anything above 35% is considered normal. Let's see how it's done. So you identify a papillary muscle level short axis image, parasternal short axis image, and then you trace your end diastolic, so that when the cavity is big, end diastolic area, and see how they traced in a way that the trabeculations and the papillary muscles are all part of your cavity. So I find this a bit confusing. In some textbooks they use different language. I always like to say that papillary muscles, trabeculations, or anything inside a cavity or inside the LV, it's part of your cavity. So you include your papillary muscles into the LV cavity because they are part of the cavity. One caveat here, you need fairly clear endocardial borders for this, as you see here, because you should be able to trace that endocardial border. The next two-dimensional measurement is your area length method, or it's almost like getting into the 3 dimensions. It uses the assumption of a bullet shape where the upper part is a prolate ellipse, and then the base is a cylinder. So then you can use these measurements, what you do. So you need to measure a length and you need to measure an area. So we already went through this in the ASE guidelines, and then you plug that in, you get a volume, you do one in systole, you do one in diastole, and then you get an EF out of that. Can be done. I don't do very often, but it's a method that is available to us if all the others are not. And then we'll move on to the modified Simpson's biplane. That what we use, it can use in the ICU. It is very time consuming, and for learning and when you develop your skills, definitely have to practice it because it's the gold standard. It's the method of discs, as I explained before. It's using fewer assumptions, and you add up the volume of those discs, and then the machine will plug it in for you and gives you an EF number. This is how it's done in real. So you optimize your image as you see here. So you're optimizing your image so that mostly the LV is filling up the whole image. You identify your apical 4-chamber view images, which is there, and you do 2 measurements there, end systole and end diastole. And then you do the same again in apical 2-chamber view. You do an end systole and end diastole image. And then the machine, from all of these measurements, the machine will give you volumes of the LV, end systole and end diastole, and then it gives you a biplane EF measurement. In this case, it was 65%. So some of these measurements, you have to be careful that you don't foreshorten the image. It's always a problem. See how this image is somewhat foreshortened, because the actual heart is a bit rounded. It's not really pointy. It should be pointy. The LV apex, see how it's a bit thick, and it's thickening. So it shouldn't be thickening too much. It should be pointy, not rounded, and not thickening too much. So then you know that it's the true apex. If it's rounded and it looks more like a rounded sphere, then it's more likely foreshortened. Another caveat for this is that MR, I mentioned that already, hypovolemia, obstruction, HOCM, other things, many things. There's many caveats, so we're going to be covering this in my cardiac output talk. So, how do we put all of the above together? So you want to develop your skills in visual assessment. So that's your holy grail. So that's what we teach. That's what we use in ED, in ICU, in your med call. So you want to do a quick, dirty visual assessment. That everyone wants this. Everyone wants to know how to do this. And again, I mentioned that sometimes there's a disconnect, that people don't want to learn how to do measurements. They only want to know how to do visual assessment, but the two go in hand, as I explained it over the previous slides. So how do we do this visual assessment? We try to take as many views and as many images of that LV as we can, so that we include as many segments and as many parts of the LV as we can and form a global view. We're looking at the walls of that LV. Is the myocardium thickening? Is it moving inwards? We have a look at the geometry of that movement. Is the annulus moving up and down? Is that torsion kind of movement present? Is the circular movement present or circumferential movement present? Is the longitudinal movement present? So all of those geometry things that we mentioned before. So we try to have a look at that. And then we try to form an overall impression, as you see here. So it comes from experience, so I'd like to stress that. So experience is key. However, yes, sometimes you have to use your imagination, and a little bit of intuition is important in that as well, that as you develop your skills, you rely on your experience, but sometimes our ICU images are less than optimal, and we still have to make up our minds, and we still have to make decisions on those patients. So then we use our imagination and intuition, and then we make up our mind. And saying all that, there's good literature to support the visual assessment. They do it in cardiology as well. They look at the heart and they come up with an LVEF by visual assessment. And we do it even more often in ICU or in ED or in acute care situations. So there is good inter and intra-observer agreement, and there's good literature to support that. However, only if you have developed your skills. So that this is where, let's say, 250 cases that you have done. After that, you'll be pretty good at visual assessment. All right, I will be mentioning other global LV function assessments as completeness, and some of these are Doppler measurements. If there is a mitral regurgitant jet, a suitable mitral regurgitant jet, you can use it for the MR-DP-DT, or you can use tissue Doppler and systolic velocities of the myocardium. So I'll be talking about these for the next few slides. So these can be part of your overall global LV systolic function assessment. It's a bit more complicated. It's a measurement. It's more complex. You need to have better skills, more skills in your echo studies, but they can still be used. I use DPDT. I use S prime as well. So it's a useful thing to do. So let's say for the DPDT, so DPDT means that pressure change over time, and it's a relatively load independent measure. You're trying to see how much, or how quickly the pressure rise is occurring, how quickly the pressure change can be generated by that LV. And the thinking is that the faster it can generate that big pressure change, then the global LV function is better. So when there is an MR and if you look at your 4-chamber view, so when there is an MR, there'll be an MR jet from the LV into the LA. So that represents a pressure difference between a high pressure zone into a low pressure zone between the LV and the LA. And what we measure is how quickly the pressure equilibrates between the high and the low pressure chambers. So what does it look like? You need an MR jet, of course. And once you have your MR jet, you have to slow your sweep speed down, meaning that you have to make it easier for you to measure this. So you need 1 or 2 of these in one screen. So that's an MR jet under the baseline. So going away from your probe. See how the meters per sec, so that's the velocity. So it's going into the LA from the LV. And you pick 2 arbitrary points on that. So from 1 meters per sec to 3 meters per sec. And you'd like to know how quickly it occurred, this change between how quickly the velocity went from 1 to 3 meters per sec. And if you think back into that modified Bernoulli equation, so 4v squared, we use that. So 1 meters per sec corresponds to 4 millimeters of mercury. 3 meters per sec, 36 millimeters of mercury based on the modified Bernoulli equation. So what you're really looking at, a pressure change of 32 millimeters of mercury. So from 4 to 36. So this is where the pressure is 4 millimeters of mercury. This is where the pressure is 36 millimeters of mercury. So how quickly this change took place. And you plug it into that equation. So the normal value is 1200. So see how it's a very, very short time that we plug in. So that's why the number is pretty high. So more than 1200 millimeters of mercury over sec. And if normal, it means that the LV is able to generate this change very rapidly. There's a few caveats. So we assume the LA pressure to be constant. We assume the LA to be compliant to receive that MR jet. We'd like to take a good quality MR signal, and we try to catch that MR signal right bang on through the middle. So it shouldn't be an eccentric jet. And the best for this is a secondary MR, which is central and it's easy to measure. The last thing I will talk about today is the LVS prime, which is your peak longitudinal myocardial velocity. So this is again a surrogate for LV function, and it only looks at one segment though. So you need a good alignment because it's a Doppler measurement, and you need to align your LV apex. So there's your LV, and there's your mitral valve. So you need, as you think about it, so this velocity, so you're looking at the velocity of the myocardium at this site. So these numbers, so the velocity will be less and less as we move closer to the apex. So that's why you really need to be on that annulus, mitral annulus, and on the myocardium close to that. You can do it lateral, you can do it septal, and then average the two. And there is a good correlation. It's been shown that the EF and mitral annular velocities do agree pretty well. And since it is a measure again of the mitral annulus, so any sort of calcification, surgeries, prosthetic valves, wall motion abnormalities, translational movement. So all these are caveats, and we shouldn't be using when these are present. How it looks in real. So you try to identify your mitral annulus. So you can do the lateral one, or you can do the septal one, and then you do a tissue Doppler, pulsed wave Doppler measurement, as you see here, with the sample volume right there in the lateral annulus, or the sample volume right there in the medial annulus. And this is the waveform that you're getting. What we're interested in this time is the S wave, which is systolic velocity above the baseline coming towards the apex. And try not to do this because that's the isovolumetric contraction. So the S wave is the second one here. Same there. So this is isovolumetric contraction, the first little one, and then the second peak will be your S prime, and this is what we measure. All right. So as a summary, we have gone through a lot, and all of the above that I've been describing to you, in one way or another, we tend to use these every day. One or two, many or some. In some patients, all of them. In some patients, only one or none. So it's important to know about these. It's important to know how to do these. And it's important to put it all together and try to summarize everything that we've learned today. However, again, just a global LV systolic function is one thing to mention. Another is to talk about cardiac output. So I'll be covering that more in a later talk. You need to think about your loading conditions, both the pre and after load conditions. You might want to find some more load independent things like the DP/DT. So nevertheless, ultimately, we'd like to know how that heart is performing, how much blood is used for the systemic circulation, and how much our organs are perfused, and we try to integrate into our clinical picture. All right, so this is the end for today. I will show you what I'll be covering in the next talk. So I would recommend, I would really recommend you to watch the next video, in which I will show you a ton of images, a ton of loops, really heaps of loops, and trying to train your eyes for how to do that visual estimation. So I'll just give you a bit of a preview on that, on what we do. So this is a normal heart, normal systolic function. So how do we assess this systolic function? So first of all, we try to take as many images as we can. So we have a parasternal long, a parasternal short, and we have an apical 4-chamber view. We optimizing our image for the best endocardial definition. We have a look. If first, no need to measure anything, like no need to measure or know even the cutoff values. So first, using these centimeter markings here, you have a look. Is this LV severely dilated? Is it more than 6 centimeters? And then you can already comment on that LV size, just a rough measure. And then, even without measuring it too much, you kind of have a look at that cavity right in the middle. You think of those two measurements that we do for fractional shortening, the diastolic and systolic diameter measurements. Is this a normal fractional shortening or not? And then we can do a fractional area change, and a diastolic and the systolic area. Is this a normal fractional area change? So we did diameter there, we did a fractional shortening there, we did a fractional area change there. If not measuring it, not doing the actual measurements, but in our mind, we're using it as a rough semi-quantitative thing. And then we can do those other measures that we were looking at. So you look at that E-point septal separation. Is that mitral valve coming very close to the septum? Is this a normal E-point septal separation? And then we can look at the mitral annulus and then look at that MAP-C. MAP-C. Is this a normal MAP-C or an abnormal MAP-C? Again, we're not measuring it, we're not doing the M mode, it's just we're using these three images to look at is this a normal MAP-C or not a normal MAP-C. And then when you, after that, you try to assign a visual estimation EF. So you put your pointer in the middle. Is this cavity getting smaller and bigger? Is the walls coming in? Are they thickening? What do I think about how much is that cavity is thickening or cavity is getting smaller and bigger? What do I think about that ejection fraction just by visual estimation? Is this a normal heart? Is this abnormal? How abnormal if it's abnormal? And then without even measuring anything concretely, then you can kind of make up your mind. You can say that this is a normal systolic function by visual estimation. No need to use these numbers. You can also say that by visual estimation, my EF estimate is 55 to 60%. So that's by visual estimation. And we haven't done one single measurement. We just used our theoretical knowledge on assessing a global LV function. So that was a preview into the next lecture. So I'll be showing to you 50 or 60 hearts with the same format. And then we'll be covering and trying to train your eyes for that visual assessment. So I'll see you in that next talk. As a summary, try to learn and do as many quantitative measures as you can. And then once you developed your skills, you use them semi-quantitatively when you're more experienced. You should always aim for a best image quality. And just keep scanning, keep scanning as many as you can, as much as you can. So thank you for listening, and I'll see you in that next talk when we're going to talk about visual estimation and develop your skills. Thanks for watching. Bye-bye.